Welcome to the Psyched to Practice podcast, your one stop for practical and useful clinical information, masterful insights from experts in the field, and a guide to daily living. I'm Christner, and today I'm flying solo, and I had the opportunity to do a great interaction and interview with Hailey Frazier. Really spent time today talking about Tourette's and tic disorders, but specifically around the idea of using CBIT, comprehensive behavioral intervention for tics. And this is just a great intervention that has a large amount of research and is something that I don't think we hear a lot about, but something we really wanted to kind of share on our show. And, she just gave, so many great tips. And for me, I've worked with CBIT or CBIT for a long time and have worked with tic disorders in my career. And, just hearing kind of her story and how she approaches it, even from doing this work really gave me a great opportunity to just kind of refine some of my own knowledge. So for those who aren't familiar with Hailey Frazier, Hailey is a clinician specializing in neurodevelopmental disorders at Grounded Roots Family Developmental Center in Abilene, Texas. She specializes in assessment and intervention for autism, ADHD, Tourette's, and dyslexia. Hailey is a parent to children with Tourette's, and she herself talks about living with tics and really brings kind of this personal and affirming approach to her work with children and families who are navigating Tourette's and tic disorders. So it was really a privilege for me to have the opportunity to talk with her and to really get her insight and personal experience. For those of you who are listening, if you have thoughts or ideas you want to share, please join us on social media. We'd love to hear from you. And I hope you enjoyed this episode. Tic Talk, evidence-based support for tics and Tourette's. So Hailey, thanks so much for joining me on Psyched to Practice. I'm really excited to have a moment to chat with you today.
Yes, I'm really excited to be here.
Yeah, this is great. So we're, before we get into the topic at hand, we always like to kind of have our listeners get a sense of the guests that we have on. And so we always kind of say we want to hear a little bit about your origins story into becoming, into the field of psychology or mental health. So tell us a little bit about you and how you got into the field.
Yeah, I think I've always been pretty fascinated with psychology and human behavior, and in particular, neurodevelopmental disorders and how that might manifest in childhood. And so I've just really progressed and grown that professionally and in my personal life and gotten some pretty life lessons on those sorts of things as I've gone on. My background is in school psychology. That's what my graduate degree is in. And so that really gave me a strong foundation of behavioral science. And that's really informed my current work in assessment, but then also in the comprehensive behavioral intervention for tics that we're going to talk about today.
Yeah, that's great. And it's interesting when I kind of found out a little bit about you and we kind of connected, one of the things, it's an area that I've working with Tourette's and doing CBIT work, but I find there's not a lot of school psychologists that have that experience, which I think is really unique in that you have had that experience in working with Tourette's and CBIT. So how did you transition into this as an area of expertise?
Yeah, it's kind of funny. And I really got into school psychology. I was young, I was 22, 23, right out of undergrad, and just thought this is what I'm going to go do and, practice for several years before I started having my own kids. And then, of course, it's like, oh, you're seeing, child development in real time. And it's really interesting. And so, on a personal level, too, I think a lot of adults in our generation are really finding things out about themselves as they have kids that are getting maybe diagnosed or, concerns with their kids. And so that's really my personal story with Tourette's, too, is that I've recognize now that I've always had tics. I just didn't know what they were. Even going through graduate work in child development, it wasn't until my own oldest son was diagnosed with Tourette's that I was like, oh, wait, I actually have tics too.
Wow.
So really wanting to dive into CBIT because it really marries my passion for helping kids with a lived experience that is just the reality for myself and my family.
Wow. Yeah, that's so fascinating though. So you go clear through graduate school, supposed to understand the world of neurodevelopment and, mental health. And it took that personal experience before even kind of noticing what you experienced throughout your life. You've experienced having tics?
Yeah. I mean, I can remember as a child having tics and, my parents saying like, oh, you just have allergies or, hey, stop clearing your throat and stuff like that. And it wasn't as apparent maybe as some kids have or even adults have, but certainly after really stressful times in my life, like after the birth of my first child, I noticed that they came back really bad. And that's true for tic disorders. They just wax and wane over the lifetime. And so I don't remember really having them in college much, but I can certainly look back on my childhood and then some of my early adulthood and say, okay, yeah, that was definitely, and I have them now. You may hear some of them come out as we have our conversation today.
Right. Yeah. So in times when maybe you're under pressure, they can.
Yeah.
Yeah. Yeah. So I think this is maybe a great segue into I worked with Tourette's for a number of years, and there's just all kinds of misconceptions I think about Tourette's and tics, and I'd be curious with your expertise, maybe if you could share a little bit or explain what actually Tourette's is, and then maybe about what isn't Tourette's, which I think is also kind of important. So what's your view?
Well, absolutely is it a neurodevelopmental condition. Absolutely. It's brain-based. It just like all the other neurodevelopmental disorders, autism and ADHD, it's something that you are innately born with. It's not something that you acquire. And I think the big misconception that is just perpetuated by media is that Tourette's is just cursing, right? It's just this uncontrollable cursing. And in reality, that's very few people's presentation, right? I think the latest data I saw said maybe 1 in 10 have some sort of inappropriate vocalizations as part of their tic picture. So again, very common misconception that is what Tourette's is. In reality, the comorbidities that exist with Tourette's are oftentimes the more impairing aspects of Tourette's. So over 90% of people with Tourette's have a comorbidity.
Wow.
Including ADHD, OCD, autism, anxiety, learning differences, sensory processing issues. There's all kinds of comorbidities that I hear from clients and from others in the tic community that are way more impairing than the tics themselves. And talking from my own experience, I certainly had high anxiety, OCD behaviors as a child and all through my life that were way more impairing than, say, the outward signs of tics.
So we've used terms like Tourette's and tics, and while they're not necessarily the same.
Sure.
So tell us what makes Tourette's different than just someone who has general tics.
Well, the way you treat them, maybe there's not so much of a difference, in my opinion.
Yeah.
So Tourette's, you have to have a combination of motor and vocal tics for over a year, a history for over a year. So technically, if your kid is 7 and they've had them for 11 months, they don't have Tourette's yet. Right. And then tics can just be, you maybe just have a motor tic or just have a vocal tic, but not both. That would be like an unspecified tic disorder. Or I don't know too much about functional tic disorder, but that is another
issue. Yeah.
Issue altogether that I'm not quite up to date on the research of how that integrates with CBIT and our understanding of tics and functional tics as a neurodevelopmental condition.
Yeah. Yeah. I appreciate you bringing up about, I think the idea of corporelia, where, people swearing is what most people think of. And that's, we've seen it in movies, all of those things. But, the reality is tics, look a lot of different ways. And
absolutely.
What are kind of the more common tics that you see in those that you work with or part of the, that tic community? What are the more common ones that really we see?
I would say the most common ones have to do with the face and upper limbs.
Mm-hmm.
It's less common for the legs or torso to be affected, but it certainly does happen. Vocal tics, common ones are like throat clearing, sniffing, sometimes repeating a word. My second son has one right now where he'll say, "Excuse me, excuse me." So just repeating words like that. The motor ones that are more common are sometimes like shoulder shrugs or like wipes sometimes, or really hard blinks. So they're not always super noticeable, right? Unless you're really trained and honed in on what is that thing that they keep doing. You may not even recognize it as a tic or Tourette's because it just looks like, oh, that's just this sort of strange repetitive thing that this kid is doing.
Right. Well, and I always kind of find that's what I think that's a real misconception as well, is that I've had teachers who go, oh, they just keep doing this and they just need to kind of stop it, and I know we're going to talk about some interventions here in a bit, but I think for I'm interested in like for those who maybe come across someone in their office, whether it be school or just, private practice, and they have a question, maybe there's a behavior that they're seeing that they go, oh, I wonder if this is a tic. What are your thoughts on how they could what should they ask to help understand, is this something that's a tic? Is there a line of questioning that might help get clarification? Yeah,
for sure. And, I've had experiences with clients in my own practice that I'm like, is that a tic that you're doing, or is that just like something that since ADHD is often such an overlap, it's like, is that just an impulsive kind of behavior that you are doing? But really just get curious about their internal experience of it. Yeah. So tics always have what's called a premonitory urge, which is like a feeling or a thought that happens before the tic. And young children especially, may not always be able to tell you what that is. But if you start probing and asking, if it's a tic, they will probably tell you, I just feel this, like I have to do it. I feel like something's not right, or I feel like I have to even things up in my body or something like that. And that's, to me, like red flag. That's a premonitory urge right there. That's not something that they're controlling and just doing on their own.
Yeah. And that's very different than someone who maybe is stimming. It's I think, and I like that kind of line of questioning of just kind of trying to find out what happens before, which is really important. And I think, in my work, that's been the key. And I do find it definitely easier as kids get older. Mm-hmm. But I've been doing this a long time, but I'm always surprised sometimes what is a tic. Like I had a young man, we're going to get into CBIT here. And what got me into it, when I trained in it many years ago, was a kid that when I was working in a school as a school psychologist was chewing the inside of his mouth raw. Had scarring on the inside of his mouth, and really hearing about that urge and what kind of, was happening with him, and him not knowing how to find something different. And it was painful. And it was one of the most emotional cases that I had, because I felt as a clinician helpless. I didn't know what to tell him, and his parents didn't know what to do. And it was, and he's wearing devices in his mouth. There's all these things that everyone was trying. And so that leads me into, we're going to talk about CBIT. That was a life changer for this young man, and really was, I was lucky to have the opportunity to kind of learn about it, and it fit really well with my whole CBT background. So we keep using the acronym, CBIT. Let's tell everybody a little bit about what CBIT is and kind of maybe give us a little overview.
Sure. And Ray, you call it CBIT and I say CBIT. So we'll probably use
CBIT. Yeah.
We'll probably use
both.
Use them interchangeably as we talk.
Yeah, that's fine. Yep.
Really, CBIT has multiple branches of intervention that you can do with families and throughout the treatment process. So it really all starts with psychoeducation for the family around what is Tourette's, what are tics, what's a vocal tic, what's a motor tic, what it is, what it isn't, kind of what we've talked about already. And then, this is where I think really our school psychologists are pretty primed for this sort of treatment, is that you actually do a functional behavior assessment around the tic. And so like where it happens the most, who's around, are you getting inadvertently either rewarded or punished for the tic? And so, that's just something that we as school psychologists do all the time.
Right.
For really complex behaviors, but this is one discrete little behavior. And so I've really enjoyed doing those functional assessments around the tic. And then, of course, trying to come up with some environmental modifications that could help the kiddo. And then habit reversal training, which is that awareness training that I was talking about that premonitory urge. So getting the child or the adult to recognize that urge before the tic happens so that they're aware of it. And oftentimes kids especially will say, well, I don't feel anything before it. Like, okay, well, let's explore that a little bit. And so you'll do some awareness training around when the tic is happening, or kind of there's signals in their body that they get to recognize when it's going to happen. And then competing response training, which is basically coming up with an alternative competing response to the tic that makes the tic incompatible. It's incompatible with the tic. And yeah, you saying that you've had definitely some cases that stick with you. I've definitely had some cases that stick with me around that competing response training. I had an adolescent in my office that was just really struggling with his tics and feeling like they were just controlling his life. And the time that we got to the competing response training and he had some power and something to do about his tics, he turned to me and he was like, how are you doing this? And I said, I'm not doing it. You're doing it.
Yeah.
And that's so powerful for these kids to get to have that sense of personal accomplishment and control over something that has oftentimes felt like it's controlled their life for a really long time.
Yeah, I love that. And that's been my experience as well, is that it really, even the first time they do it and it works, and to see that reaction. And I even think it's before that competing response. I mean, I've even had kids who go, I can't tell when I'm going to have that. And I'm sure you do something similar. And, Doug Wood has done many things around this, but it's, just having a session with somebody and going, listen, I just want you to raise your hand every time you think you're going to have the tic. And if you raise your hand before I do it, I'm just going to say, good job. If not, I'm going to say, hey, just pay attention. And that simple awareness and, it's control, right? I mean, I think it's this idea of, wait a second, I do know, and I'm aware. And especially little guys, little be 7 and 8 year olds who go, yeah, like I can do this. And then they get to a really high percentage of feeling that urge and that understanding of their body. And, I think that's why I like that work. I mean, it's like, and when they get to that, that level, I'm like, we're all excited.
Yeah. Yeah.
Such a great thing. So there's so many, I think, moments in doing CBIT that we have that time, right? Yeah, it's great.
I think equally there's some pretty predictable, challenging moments that come up almost predictably in the course of treatment.
Yeah.
That first session or two, they are so excited. It's working. Yeah. However, sometimes after that first or second session where you've drawn a lot of attention to the tics, they're really on high alert about it. We've spent an hour or more talking in the office all about them. I frequently will tell parents, you probably will notice the tics more They may or may not actually be happening more, but you're going to notice them more because we've drawn attention to them. And then somewhere in the middle of treatment, kids get real bored about it. They're like, okay, yes, I know. Yes, I know I'm going to do my tick blocker, and we've got to come up with a, response. And and that's when I know, okay, they're about ready to start flying on their own.
Yeah. Yeah. So that's interesting. So that I'm going to use the word boredom. I don't know if you use that when they get to that point. That's kind of your sign that maybe they're ready to fly.
Yeah. And I think too, if they're not ready, if they still need some work, then that again is where we can kind of put on our behavioral psychology hats and say, hey, let's come up with some sort of reward for you. If you do after session, you get to go get ice cream with mom, or if you do your homework 4 days this week, you're going to get this new toy. And like kids are obviously very motivated for those kinds of things. And so we have the strategies already to help kids be successful in this process.
So I want to kind of hit on a point with, when we're talking about CBIT and habit reversal training and competing responses, this is not the same as telling a kid to hold in their tics, right? No. So can you talk a little bit about that and why it's different?
Yeah. So with habit reversal and competing response training, it's doing something. It's not doing something. Does that answer it a little bit? I wish I knew maybe more about exactly why that works. But when you tell a child, just don't do that, it's not going to work. But when you give them something to do instead that's incompatible with doing the tic, and when they come up with that kind of thing on their own, that's empowering for them and they're motivated to do it. And it's something that they can do, not just something that they're white knuckling trying not to do.
Right. And I think in my experience is that when kids have been told, stop it, don't do it, it in fact exacerbates it. It actually makes it worse. The more that they try to not do it, the more intense the urge gets, the more, and sometimes even, and I know that tics can move around, but sometimes I've seen kids that then develop even more severe, complex tics because of that. And I appreciate your comment about like it's about doing. This isn't about eliminating tics. It's about creating different ways to deal with that urge.
Absolutely.
Is that how you agree? I mean, that's how I've always perceived it. We're not eliminating the urge. We're no. Way around it, right?
And it's almost like a little bit of like frustration tolerance too, because that urge is really strong in some kids and for certain tics. And talking again about predictable patterns, there will usually come a point where a kid breaks down in tears because they're like, the urge is just too strong. The urge is just too strong. I can't do it. And so using that as an opportunity to support and to work through that with them, find another competing response if the one that they're trying isn't working, but building up that frustration tolerance for that discomfort that premonitory urge is really important too.
So I'm curious about what's the research behind all of this? I mean, as far as we know, this is all very much in the behavioral world that has a lot of research. What's the, I know we can't go through all of it, but what are maybe some highlights on like, is there research to support this or do we see good outcomes with CBIT?
There is a lot of good research to support this. The University of Utah has done several studies about the efficacy of CBIT, and the Tourette Association of America is the go-to resource for finding legitimate research articles on this treatment. And I really think that this treatment borrows from a lot of already well-established behavioral theories that are time-tested. It just expands it to this new population.
Yeah. Well, it's interesting. When I said I kind of got started because of one kid, and I, and the Tourette's Association it's how I kind of hooked up with doing some training that they had with Doug Wood that was going on, and it was like, oh, this is awesome. This is like kind of great. But I thought one of the things for me was I was surprised how familiar it was to me. Like it was. I was expecting I was going to learn this whole new thing because it's, I thought it was going to be really complex. And then kind of, you said this earlier, it was like, wait, this is an FBA. This is
exactly.
Like I've done 1,000 of these. This is like really, and I think what people think might be so difficult is really, I found that it was many skills, probably 80% of what was already in my wheelhouse, paired with maybe 20% of how to use those skills differently. Is that how you felt, or like, do you see that different?
No, I think that's true. Especially if you've gone through a program that has a really strong behavior focus.
Yeah.
You know the basis already. You know the foundations. And so, I would just say to school psychologists out there, like, please jump in, because this is well within our wheelhouse.
Yeah, absolutely. And it's, I think once, for me, once I did a few cases, it became, there wasn't a lot of people. I ended up having a lot of, going to a lot of different schools to do this type of work. And it was actually, as a school psychologist, refreshing. And I enjoyed, seeing the kids' reactions and the working with families just in a different way. So for those that maybe aren't familiar, and I know we've kind of hit some pieces on this, but can you walk us through a little bit of what might CBIT look like for, I don't know if we can say a typical client. I mean, but is there, with someone that you work with, maybe walk us through what that might look like? Yes.
Typically, it starts with a parent calling that has tried everything, and I mean everything before finding CBIT. They've tried supplements, they've tried elimination diets, they've tried ultraviolet light therapy and the chiropractor, and they have tried everything. And I understand as a parent, because it's so difficult to watch your child go through something like that and be so distressed about it. So that's where it starts. And then it really starts with education for the whole family and for the child or adolescent, or maybe even an adult who has the tics, right? Because it's not even well understood to the people who are experiencing it and the families that are experiencing it. That may include talking to the child's school about how they can help, because it really is a wraparound intervention that needs to be implemented in each and every setting that the client is in. I'll give you a little bit of an example from my own son. He's given me permission to share this story, but
okay, awesome. That's great.
He was having just a really hard time with his tics, and he was in first grade and would almost just fall out of his seat. His tics were so bad, and he was kind of throwing himself. And so for a little while, unbeknownst to me, he would get to go to the nurse to calm down and have a little bit of quiet time when he had these tics that got so bad. Well, well-meaning adults in any setting can inadvertently reinforce the environmental factors that contribute to the tics. So, my son was getting to go talk to the pretty school nurse and get a juice box and get to talk about his day and rest and listen to music. And so when I found out about that, I called and I said, okay, I love what y'all are doing to try to help him, but it's actually probably not what he needs, He needs to be in class. And so even in those early sessions, collaborating with the schools and with the parents to make any kind of environmental change that we can be as seamless as possible and make sense to not reinforce the behavior and the tic, right? And then, of course, like I said, the middle sessions are all about awareness training, convening response training, working on tic priority. I always start with where does the kid want to start? The parent may be super annoyed by some particular tic, and the child may say, oh, I barely notice I do that. I'm like, okay, well, which one is the most disturbing to you? Because that's where I want to start. Because once they find out that, oh, this is really rewarding for me to not have this really painful or annoying tic in my life, then they can say, okay, well, now I can work on these other ones that maybe aren't so.
Yeah, I love that. I think that's such an important piece. I mean, I know in my own work, I think what I did wrong initially was I made the assumption of what tic I thought they would want to get rid of. It was like kind of like, oh, this one has to be. And what I think I've found over time is, one, I could be completely off. Even the one that might be painful. I've had kids who have had painful tics and they go, yeah, I don't want to work on that one. I want to work on a different one. And what I've found is, I think we get different kinds of kids and families. And I found some kids who just want to do the easiest one for them to see if it works.
Yeah.
And it creates a buy-in for them. And because the other ones just feel maybe too big, too overwhelming. And then I've had other kids who are like, I want to knock this one out because this was, and it's maybe the hardest. Maybe it's the one that, but, not jumping to that assumption. And I found for me a barrier, and I shouldn't say a barrier, the school and parents might have a completely different agenda. And they're like, I had a school who go, going back to, swearing. They're like, oh no, we have to eliminate this one. They're not ready yet. That's not the one that's bothersome to them. That's not the one, and that's a hard sell. I found that it's a hard sell sometimes. And have you had, I guess, that barrier? Are there other barriers that you've run into with either parents or schools that we have to work around to help make it successful?
There is still a lot of misunderstanding with schools. Yeah. And I think it's important for parents to advocate and for us as professionals to help parents advocate for some sort of either 504 plan, maybe in some cases special education intervention, because the adults that work with these children need to know what they need to be successful. And when a child's told just, don't do that, or I know what a tic is, that's not a tic. I know what Tourette's is.
Right.
That is so inappropriate for one thing, and just disempowering to this poor child who they don't even know what this kid's going through. And so helping parents and helping schools get on board with, we're in this together and here's the approach we need to take. And that does take some extra time and attention from us as professionals, but it really is necessary in order to provide this real wraparound service for these families.
Such a great point. I mean, I think as professionals, making sure that we are advocating for that, and I honestly, I think from just experience, I've learned to check my own behavior and comments. When you said that's not a tic, I can't tell you how many times in my career I've had a teacher go, that can't be a tic. I don't know if it can or not. But I will say, it's interesting. I mean, and you made a comment, and we make this comment on the show all the time. Being curious is so important in this work, and really kind of getting to understand that. And I just had a case just not too long ago, a young guy who his tic was stabbing up the paper in class with his pencil. He would poke holes in. And was getting suspended, and it was, and they're like, that can't be a tic. Like a tic's blinking or coughing, and it's like, well, yeah, you're right. Like that could be that, but this could be too. And hearing his story about the tic and what happened, and it's we have to be more curious and not jump to those conclusions. And how do you approach that with schools? I guess I'm kind of curious. I mean, I kind of have my thoughts, but I'm curious, how when you have schools that maybe are struggling with understanding it, what has worked for you?
I have said out loud in meetings, we're gonna treat this like a tic until it's proven otherwise.
Great. Yeah.
And we're going to do CBIT around it, and we're going to work through it. And, 9 times out of 10, it is a tic. They just want to get rid of it. And so they punish it. So they don't want to think that it is. But if we target it like a tic, or even take behavioral approaches to eliminating a behavior, that's the goal, right? That's the goal for everybody. This kid doesn't want to be doing it either.
Right.
So let's do what we can as a team to get there.
Yeah, I love that. I love the idea of let's treat it like it until proven otherwise. I think that's important. And I think it helps the kid feel heard. I mean, I think when we do that, and there's power just in that. I mean, just the fact that people listen. I mean, I think so important. I want to jump back and maybe a little off of the CBIT for a second, but I don't know, you're giving me all these thoughts in my head. that I want to talk about. You kind of made a comment of, maybe we need to look at a 504, maybe we need to look at special education. One of the things that I've experienced is that many times on the surface in school, the child's doing okay. They're doing all right.
They're gifted even.
What's that?
They're gifted even.
You're right. So our grades are good. And there are times maybe even the tics are not as prominent in school. And then I hear a whole different circumstance from the parents when they get home from school. That for lack of a better term, trying to hold it together all day and the fatigue and the impact that it has. Then I've had kids who, for hours after school, have had a really rough time and even some emotionality. What are your thoughts on, is that something that in school, that's why we need to kind of look at, is there a way to maybe minimize that mental fatigue? And how can we better talk to schools about that?
Every school culture is so different. And so the openness of each school to look into this kind of support might be different. However, asking for a separate testing area, if that is what is going to make them anxious and have their tics come out more. That's not a big deal. A time to go stand at the back of class and if they have a motor tic or something so that the whole class doesn't see them. That's not a big deal. So I think most schools are getting on board with little things like that. Yeah. That would make sense. Bigger interventions, I think we still have a long way to go.
Yeah, I agree. I would say in my career, I've seen, and I think partially because of some of the advocacy through the Tourette's community and Tic community, that we're seeing much better understanding than when I started as a school psychologist almost 30 years ago. And not that it was new then, but I think the understanding was just very different. And I have found that some difficulties at times, but most often now schools having a higher level of awareness that we can have an easier inroad. Are you seeing that as well? Depends.
I actually don't see that as much here where I am.
Okay.
There's very little acknowledgement that Tourette's or tics could actually even be, something that a child in their school could have. I think there's some misconceptions too around the prevalence of it. And it's actually not incredibly uncommon. Something like 1 in 100 kids is going to have a tic, either transient or Tourette's at some points in their life. That's not a small number. That's, 1, 2, 3, 4 kids on a campus at any given time.
Right.
But like you said, it's not always super apparent within the school setting. Well,
and I think maybe in my experience, the other here in Pennsylvania, I'll give a shout out to the Pennsylvania Tourette's Syndrome Association. They are incredible. They are such a powerhouse organization that's small, not a big organization, but I think their advocacy and education has gone a long way in my career. And I think that definitely has helped for sure. At least give some awareness, which is important. So we talked earlier, we both kind of maybe gave a little bit of some powerful moments in doing this kind of work, but I guess maybe revisiting that a little bit. Would you be comfortable maybe sharing a little bit about maybe kind of a moving moment that you've experienced during doing CBIT and something maybe that kind of stuck with you in doing this work?
The empowerment that kids feel when they have even that tiniest little bit of power over their tics is an honor to watch because they are overcoming something that's been a huge part of their life for a really long time and will continue to be part of their life. Tourette's doesn't go away. It's not a cure. CBIT is not a cure. It's a treatment. But just knowing that someone else understands them, someone else has been there, somebody else gets everything around the tic and what it means and all the underlying stuff that's going on in their brain. Somebody gets it and sees it. and has been there and knows how to help.
Yeah. I want to kind of bounce off your comment. You made the comment treatment versus cure.
Mm-hmm.
Let's maybe talk about that for a second. How do you reframe that for people? I have had people have that expectation that this is going to take it away. What's the best way to kind of reframe that for families or even for kids that have an expectation that we're going to now eliminate their tics?
I think starting up front about, even before you book that first session with somebody, to say, this is a management tool. This is not a cure. Just like, medications don't make your conditions go away. Not usually, right? Long-term conditions, you still have your condition, even if you're medicated for it. The same thing. Just because you do CBIT doesn't mean it's not a cure. It's a management. And the goal is not to have no tics anymore. That's not the goal. The goal is to have the client feel more in control of their tics.
Yeah, I guess it keeps circling back to that empowerment, right? Mm-hmm. It's control, empowerment, feeling that it's something that we can do something with. That's kind of the language I've always used as well. It really is just a management piece of it. So if somebody's thinking about CBIT, how do we know if it's the right fit or not? Like, is there, when maybe somebody needs something else different or something first, or is that always your go-to first? Like, how do you make that decision?
In private practice, I get a lot of very concerned parents calling, right? And usually one of my first questions is, how does the child feel about doing this? Right. Because if the child is pretty indifferent or doesn't really care about their tics, or they're not really bothered by them, then CBIT's not really going to work. And so, I'll say, hey, I am happy to meet with you and even you and your child and do some psychoeducation around Tourette's. But, until he or she is really bothered and wants to make this behavior change, because that's what it is, it's behavior change, then it's probably kind of a waste of your money. So let's try something else first. Another situation where I'd probably want to look at treating some of those underlying conditions first is if the underlying ADHD is so unmanaged that the child can't sit through a session or can't concentrate to get through a session, that may need to be addressed before CBIT is started. And oftentimes there will be, maybe not oftentimes, but sometimes there will be a much bigger concern for like OCD type behavior and thoughts that needs to be addressed first, or is the bigger presenting concern.
So that those coexisting pieces, they could inhibit the outcomes of CBIT if we don't kind of explore that. I think that's really important. I agree. I kind of do something similar. And I've had some families who want to still do the CBIT kind of first, and I've tried it, but we sometimes have to go back to that. We've used the term behavioral a lot, and I just as we're kind of getting to the end here, but so we're talking about using behavioral interventions for a neurological condition. Right. So it's like, so I think the common thought is that it's neurological. Like, you got to go see a neurologist. It's only going to be medication or some type of medical intervention. And then all of a sudden we're saying, oh no, hey, this treatment and management's behavioral. Can you talk about that a little bit? And how do we treat it behaviorally if it's neurological?
Yeah. And, sometimes I'll have teachers or parents say, well, if they can control it through CBIT, then they can just control it all the time, right?
Right.
No, 100% unequivocally, it is a neurological condition. Full stop. Children and adults with Tourette's are not being willfully disobedient or purposefully annoying. However, just with almost everything in our daily lives, the principles of behavior reinforcement and punishment apply here. And so the more we can encourage children to be comfortable, the more we can encourage children to use the competing responses that they've learned and reinforce that, the more we can avoid reinforcing tic behaviors that we don't want through, like the example I gave earlier.
Yeah.
That is how the behavior component comes in. And just like every other aspect of our lives.
Yeah. And I think it goes even back to that cure versus treatment. I think as we learn about most kind of conditions, even in mental health in general, they all have a neurological basis,
of course,
to them, or at least a lot of them do. And we still find behavioral treatments that can be very effective. And I don't see this as being any different. So, I mean, I tell parents all the time, like, depression has a neurogenetic base to it. And medication works. Yeah. But treatment is just through cognitive therapy can be equally as effective in managing it. And I think sometimes with Tourette's, we somehow think it's different from that. And it is.
Yeah. Yeah. And it's
still strategies we can put in place.
I guess I'm drawing a line, but kind of a connection between, oftentimes we'll tell parents, like, if your kid has ADHD, have them ride their bike to school or have them run around or, get physical movement. It's not a cure for their ADHD, but it's a behavioral management technique and intervention that just makes sense. So that's kind of a parallel maybe I'll draw there.
That's a very good parallel. I mean, I had a little guy in my office today, not that little enough, who, he stands the whole time during our therapy session. Because his ADHD doesn't let him sit down. And it's the most effective sessions we have. Sure. He wears me out and I just watching him, but again, good accommodations. So as people are listening, and we're talking about this kind of evidence-based resources, any thoughts maybe that we could share on, maybe either professionals who are looking for more information or training, or maybe families that are dealing with this, where might they learn more about CBIT, or how can they find providers? Like, is there a resource to be able to find people in their area that might be able to do this work?
Yes. And the only thing I would recommend parents do is go to the Tourette's Association of America provider directory, because those providers have been highly trained, have gone through a whole process and screening and training to complete that course of training. I have seen some parents come to me or other CBIT providers that they've been told that, oh yeah, I know CBIT. Well, really that therapist knows CBT, or they know exposure and response prevention. And there are enough differences that you do need the specific training in CBIT in order to implement the entire course of treatment. The Tourette's Association of America has so much information on their website. I tell professionals to go there. I tell parents to go there. They have conferences every year that kids can even take part in. So it is the resource for us here in America to
Yeah, I would agree. I think they have so much. And I just want to reinforce you mentioning, there's a difference between knowing behavior therapy or CBT and CBIT. And we've talked earlier, there's a lot of crossover, but it really is a sequence of how we do things that is really important. And I have had the unfortunate opportunities to have parents who have had kids in years of the wrong intervention. And I think, it's not a blaming for those professionals. No. They were trying to help, but knowing a little is dangerous. We know that. So I think that's a great resource. And I think beyond just the list of providers, for those who I think are dealing with tics, the Tourette's Association of America, is wonderful resources. It's a wealth of information. So as we kind of wrap up, we like to end by asking our guests 2 questions that we ask everyone. Nothing like putting you on the spot here. We always like to, if you have one piece of content, whether it's a book, a movie, a TV show, podcast, it can be a song, we don't care. What's something maybe you would recommend that people check out that could be interesting? I
am a very evidence-based person. And so I'm going to steer people towards evidence-based books. There's the treatments that work manuals for a therapist, and then the Understanding Tourette Syndrome from the Understanding Atypical Development book series are both really evidence-based manuals and books for providers, and the second more so for even parents to understand and have a better understanding of Tourette's.
Yeah, those are both great resources. Familiar with both of those. And kind of our last question, if you could provide our listeners or clinicians that are out there kind of 3 takeaways from the episode you kind of want people to stick with, what would those 3 things be?
We've said it so many times, but CBIT's empowering. It's empowering. It's giving kids power over their tics to choose how they want to respond to them. It can be done in a really neurodiversity affirming way. And I love that about it. I guess the second is more for professionals and parents. You don't have to be a Tourette expert to start helping. Just be curious and learn about the experience of people who are living it. If you want to get formally trained, definitely go through the Tourette's Association. I'll tag that on to the end of it. And then 3, I think we as professionals have an opportunity to really make a difference for the whole family in providing CBIT.
Yeah, that's great. Yeah, and I agree. I think those are excellent takeaways. And Hailey, I want to give a big thanks to you for joining me today. It's always good to hear other perspectives, and I really appreciate you taking the time to talk with us about CBIT and your personal experience. And thank your son for allowing the sharing of the story there. That's always good. If our listeners are interested in learning more about you and what you do, where can they follow you?
I'm pretty active on Facebook, and that my clinic is Grounded Roots Family Development Center, and that's on Facebook. I have a website that's Grounded Roots FDC, like FamilyDevelopmentCenter.com, or they can email me at Hailey@GroundedRootsFDC.com, and I'd be happy to connect with people who want to learn more about CBIT.
That's wonderful. And I hope they will take advantage of that. And the resources you talked about, we'll try to get in our show notes as well, so that it's easy for people to find these things. For those listeners who are licensed clinicians and who would like to know more about continuing education and using this as a continuing education opportunity, please head over to psychedpractice.com and check out our show notes for any links, including an accompanying exam for CE credits. If you're interested in hearing more about Psyched Practice, please join us on all major social media. Until then, we will see you in 2 weeks. Be well and stay psyched.